Symposium. It is a convention, or not a convention, but just a session in Texas that is 4 or 5 days in every December, where they, someone said, I'm unable to hear you. Can people hear me? You might want to check the volume on your computer, because it seems like everyone else is hearing. And I will try to, but the San Antonio Breast Cancer Symposium is basically where they release all of the new data and new information about things coming up in breast cancer treatment. So there's a lot of information that's reviewed there. And so we're just going to touch on some topics tonight, but I've asked the oncologist to prepare just a few highlights to go over what is new and upcoming. And just to show the agenda, tell you about the agenda, we are going to start first with Dr. Hilton. She's going to talk about triple negative breast cancer. Dr. Puhalla is talking about immunology and metastatic breast cancer. Dr. Analo will talk about ER and PR updates. And then Dr. Brufsky is going to go into HER2 positive breast cancer in early stage in the metastatic setting. All the doctors will speak first. You may ask questions in the chat. I would appreciate if you keep yourself muted for the entire length of the seminar. And then as we open things up after all the doctors have spoken, we will then, you'll be able to ask questions. Both Carol Glock and I will field those questions, just to credit, because we have about 60 people online. So we just want to keep it manageable and be respectful of the doctor's time. I can't see everybody because I put myself in a spotlight view here, but we have some great people with us tonight. One of us, I wanted to introduce Rebecca Whitlinger, who is the executive director of the Cancer Caring Center, and she is with us tonight. Wendy Myers, who is the director of counseling at the Cancer Caring Center, is with us tonight as well, which I'm very thankful to be working with them. We also have Cheryl Harris, who runs our African-American breast cancer support group, or it's just a regular cancer support group. Cheryl has been, is a 2-time survivor and is a fabulous facilitator. Carol Glock, which I should have introduced first, I'm sorry, but Carol is my co-host tonight, and she is not only a great friend, but an incredible advocate, and has a foundation based on helping people to understand clinical trials. And the fabulous thing is everything that is presented here tonight is based on a clinical trial. Every medicine that you have had has started in clinical trials. So I'll let Carol talk in a few minutes. Carol Harding is also on the line tonight, and she runs our support group for our patients in Johnstown. She does a fabulous job, so we welcome anybody from Johnstown. We have our OT students from, we are partnering with the University of Pennsylvania, or Pittsburgh, and we have 5 OT students coming with us this semester, so they're online tonight as well. And then I also, and I don't know if Peg Rosenweg is on tonight, but we appreciate her support as well. And I honestly am grateful for everybody being here. I really appreciate this and appreciate your time. I'm excited to be able to do this. I just wanted Carol to say a few words because she was very helpful in getting this event together tonight. And Carol, can you say a few things?
Well, thanks, Jen. Yes, I'm Carol Glock, founder of the Glock Foundation, and I was on a clinical trial 7 years ago, and it saved my life. And my mission of the Glock Foundation is to raise funds to support breast cancer research, clinical trials, and really to help patients. And mostly we try to encourage patients to ask their physicians about clinical trials. I go out and try to educate the population of Pittsburgh and also patients about the benefits of being on clinical trials, about individualized treatment plans, how this leads the way to improve survivorship, and how this will help the physicians find new cures. And they can't find new cures unless we are willing to try to participate in trials. So I'm really excited about tonight, and especially with all these physicians that came on board, because you know, the San Antonio Symposium is where everything happens and where all the new clinical trial findings are laid out.
Well, thank you, Carol. And our first, I'm sorry, I'm trying to do the spotlight there. Our first physician that we're going to move into is Dr. Hilton, Dr. Christy Hilton, and she is a breast center medical oncologist lead at Allegheny Health Network and is involved in breast cancer research with Allegheny Health Network and serves as the primary investigator on multiple clinical trials. And she's a core investigator with the NSABP, and is the General Breast Committee member at the NRG Oncology. Hopefully I said all that correctly. And then I am going to switch the spotlight over to you, which, let me do this real quick. And there you go. Thank you very much, Dr. Hilton.
Thank you for having me. Can you see my slides?
Yes.
Okay, great. All right, so I am tasked with covering triple negative breast cancer, the 2020 updates. I do have a conflict of interest with AstraZeneca, but I am not talking about any of their compounds tonight. So in 2020 updates, I want to talk about defining triple negative breast cancer. There have been some studies that have come out looking more at defining triple negative breast cancer by what it is instead of what it's not. I'm not going to touch on immunotherapy, which was a huge update for 2020 for triple negative breast cancer. Dr. Puhalla is going to go into that for the metastatic setting. And I'm going to focus most of my talk on sacituzumab govitecan. So triple negative breast cancer historically is defined by what it's not. So lacking expression of estrogen receptor, progesterone receptor, and HER2/neu protein. It's about 15 to 20% of all breast cancers in the United States. Compared with hormone receptor positive subtypes of breast cancer, triple negative breast cancer has a higher risk of distant recurrence, higher rates of visceral and central nervous system metastasis, early time to recurrence, and worse prognosis after recurrence. We know that it is a molecularly diverse, heterogeneous disease. It is not just one disease, and it's thought to encompass many different molecular subtypes, depending who you read, anywhere from 4 to 6 different molecular differences within triple negative breast cancer. And there's been a lot of work that was discussed at San Antonio regarding different biomarkers, and there's still ongoing studies to look at triple negative breast cancer and define it better, target it better for treatments by looking at different biomarkers. And some of them are listed here: the stromal tumor infiltrating lymphocytes, looking at homologous recombination deficiency, which is a pathway that can be deficient in women that have certain genetic mutations like BRCA, as well as other genetic mutations. Looking at the gene expression signatures, and then also PD-L1 expression, which we know is a response, allows us to gauge whether or not we think someone might respond to immunotherapy. The biologic heterogeneity is clinically evident because we know that there are some women that will have very aggressive triple negative breast cancer and others that have a more indolent course. So sacituzumab govitecan was granted accelerated approval by the FDA in April of 2020. And what it is it is a novel TROP2-directed antibody drug conjugate for the treatment of patients with metastatic triple negative breast cancer who are heavily pretreated. And in order to get into the study, you needed to have at least 2 prior therapies in the metastatic setting. So what is this compound? It's an antibody drug conjugate that contains SN38. So SN38 is the active metabolite of irinotecan, which is one of the chemotherapies that's used in other disease states. It's not typically one that's used in breast cancer treatments, and that's why some thoughts are that it has such a good response rate, because it's something that the tumor hasn't seen before. So it's that SN38, that active metabolite, that is connected to a monoclonal antibody that binds to something called TROP2. And TROP2 is a cell surface receptor that's overexpressed in many solid tumors, but it's highly overexpressed in triple negative breast cancer over 90% of the time, which makes it a good target for triple negative breast cancer. The mechanism is that the antibody moiety binds to the TROP2 receptor and then is internalized into the cell. Once it's internalized, it breaks off the active chemotherapy part and is able to kill the cell. So this is what it looks like. So you can see this is the antibody portion. This is the linker that connects the green dots, and the green dots are the payload or the chemotherapy. And the important thing is that you need to have this delivery system, because if you gave SN38 alone, it would be far too toxic to give. So you have to give it in this way. This is just a representation to make it a little bit more easy to understand. So this is your tumor cell that's purple. You have the TROP2 receptor on the tumor cell surface. The antibody drug conjugate binds to the receptor. It then gets internalized into the cell. Once it's inside the cell, it's able to take apart that linker. The chemotherapy, which is depicted by the little red dots, diffuses out, kills the tumor cell, and then is able to kill also the surrounding cells. So does the amount of TROP2 receptor expression matter? So at San Antonio this year, they did an exploratory analysis where they looked at the initial trials, and they looked at high expressors, medium expressors of that receptor, as well as low expressors. And overall, they found that the medium and high expressors did much better on the sacituzumab than the other chemotherapies. But also the low expressors also trended towards doing a little bit better. And it was too small of a amount of people to really say anything about that. So overall, you don't have to know if your tumor has overexpression of this TROP2. The sacituzumab is thought to work for all the triple negative. So the original study, the single arm open label study, looked at women who had metastatic triple negative breast cancer. They had to have more than or equal to 2 lines of therapy in the metastatic setting, an expected survival of 6 months, and they allowed women with treated stable brain metastasis. So Dr. Brufsky is going to talk in a little bit, I'm sure, about the really exciting HER2 studies that allowed women without treated brain metastasis. But in this trial, they needed to be treated. They had to have good performance statuses, and they received the sacituzumab on days 1 and 8 every 28 days, and they stayed on it until they had progression of disease on their imaging scans. So in the original small group of patients on the phase 1, 69 patients, if you would look at them, they had received anywhere from 1 to 12 prior therapies. So it was a really heavily pre-treated group of metastatic patients. And in that group, the response rate was 30%, which is fantastic, because when you look at historical data, single agent chemotherapy really provides about 10% or less response rate in the metastatic setting. So to have a response rate of 30% is really profound. There were 19 partial responses and even 2 complete responses in this heavily pretreated group. The median duration of response was 8.9 months. So that means not only did they respond, but they continued to respond or keep that response and stay on the drug for a longer period of time. And in a heavily pretreated group, this is really remarkable. The other thing that's remarkable is that the responses occurred early. So when it says with a median onset of 1.9 months, so that basically means on the trial after receiving the drug, the very first scan that you would have gotten would have shown response, and that's pretty remarkable too. Nothing comes without a cost. And this drug, the main adverse events that were significant tended to be neutropenia, or that lowering of that white blood cell count, leukopenia, the anemia, so lowering of your hemoglobin, loose stools in about 13%. And then there was a risk of febrile neutropenia, about 7%. So that's having a fever when your white count is very low. So that led to the phase 3 trial, which was discussed in 2020 at another conference called ESMO, which was a big one. And so in this trial, they looked at the same dosing that we had just talked about, the 10 milligrams per kilogram on days 1 and 8. And they included women who had greater than or equal to 2 prior chemotherapies, but they had no upper limit, which is really nice. Some of the trials in the metastatic setting, you can have just 2 prior lines of treatment. And so if you've already had 3 or 4 lines but are in good shape, you're not included in those trials. So this one allowed you to have really lots of prior chemotherapy. As long as you were in good enough shape to be treated, you could be treated on trial, which is fantastic. And one of those could have been progression of disease within 12 months of your neoadjuvant treatment before surgery. You needed to have a good performance status, and they included 529 patients. Now, this was comparing the sacituzumab with physician's choice of single agent chemotherapy, so it's an excellent trial. The physician could choose eribulin, vinorelbine, gemcitabine, or capecitabine, which are all really common single agent chemotherapies for triple negative breast cancer. And important to know that the trial was halted early because it showed such profound and wonderful results. So when you look at PFS, that's progression-free survival. If you look, you can see that the sacituzumab arm was 5.6 months versus 1.7 with the physician's choice. So much longer time on the sacituzumab arm before you started to have progression of disease. And then when you look at the overall survival, which is the length of time that the woman lives, you can also see that that was much improved with sacituzumab at 12.1 months. Looking at the safety data, it's exactly the same as what we had just talked about in the phase 1 study. You have your hematologic, so the lowering of your counts. You had GI toxicities, which were a little bit higher in the sacituzumab arm compared to the other chemotherapies, and then fatigue. And the patients that I had on the ASCENT trial, I feel like the fatigue was the most profound thing that they had complained about. Important to note, though, that even though there are toxicities with this treatment, the discontinuation rate, meaning the toxicity was high enough where they were no longer allowed to receive the drug, was only 4.7% with sacituzumab and was 5.4% on the chemotherapies of physician choice. So they tolerated it better than what the doctor would have picked otherwise. So the overall results, comparing sacituzumab to the physician's choice, showed that the progression-free survival was improved at 5.6 months versus only 1.7. The median overall survival was 12.1 months versus 6.7, which is highly significant. And the overall response rate was 35% for the sacituzumab arm versus only 5% for the treatment of physician's choice. The key treatment-related adverse events were the cytopenias, loose stools, anemia, febrile neutropenia, 6 versus 2%, but no grade 3 neuropathy or interstitial lung disease was found. And so the conclusions were that based on this study, this was the first antibody drug conjugate that was able to show a significant progression-free survival and overall survival improvement versus standard chemotherapy in a heavily treated metastatic triple-negative breast cancer population. So really quite a big deal with really great results. One thing that they talked about that I thought was interesting at San Antonio this year was looking at an exploratory analysis from that phase 3 trial for women with brain metastasis. The tough thing about brain metastasis in this trial is that they were all treated. So it's difficult with treated brain mets. Anyone who has had them knows that the images are very difficult to interpret what's progression, what's radiation necrosis, what's stable disease. So, but I think it's a good start at looking at this, and hopefully there'll be trials in the future, and there certainly are, looking at brain metastasis with this compound. So really quickly, the blood-brain barrier, it's a barrier between the blood vessels of the brain and the brain tissues. It's composed of complex cells, which create both a physical barrier as well as a functional barrier. And the functional barrier controls and regulates what can pass through that barrier. And the reason why we have that is it's needed for the brain to function. So the brain needs to function within a very tight microenvironment in a really tight homeostatic range. And so it protects the brain against pathogens passing through the blood or toxins passing through the blood. Some molecules pass freely and others don't. And the problem is that many of our chemotherapies don't freely pass through, which makes it a challenge to treat metastatic disease to the brain. So brain mets are a problem with triple negative disease as well as HER2 positive disease. And in triple negative breast cancer, the 5-year cumulative incidence of brain mets at first site of recurrence, you can see there goes up to 10% with stage 3 disease. And the choice of chemotherapy after local treatment of brain mets is based on your previous treatment, gene mutation status, and PD-L1 status. And there's lots of different things that are underway and being investigated for triple negative brain mets. Sacituzumab is one of them. I think the other important thing that came out at a lot of the meetings this year is that when you look at the molecular, so the genes within the tumor of the brain met versus the primary tumor or other metastases that aren't in the brain, they can be a little bit different. And the researchers that are working in brain metastasis are really focused on looking at profiling those tumors and finding, can you find targets for the brain mets? And there were a couple studies that people were talking about that perhaps brain mets do have actually more targetable mutations than the regular metastasis because of the way that they evolve in order to pass the blood-brain barrier. So one really quick, interesting thing that Dr. Anders talked about is on this slide. So the background of why they think that sacituzumab can cross the blood-brain barrier is in part from work like this. So this was a poster that was presented where pre-surgically women with brain mets were given sacituzumab just 1 dose on pre-op day -1. And then at the time that they had their resection, they checked the tumor, CSF, and serum sampling intraoperatively to get quantification of the amount of sacituzumab that crossed over. I am already at 15 minutes. That is nuts. Okay, I'm going to go super quick. So overall, they were able to find that it does cross the blood-brain barrier, which is very exciting. And so when they looked at the phase 3 study, they found that 61 out of the 529 patients, or 12%, were in the study that had brain metastasis. And stability was over 4 weeks, stability on imaging, as well as decreasing steroids and off of any anti-seizure medication. And what they found was that in this very small group, that the median progression-free survival for those women with stable brain mets on the sacituzumab arm was 2.8 months versus 1.6 in the treatment of physician's choice. So it was improved with the women who are on sacituzumab, not to the degree that you see overall in the study, but it was a trend towards improvement in a very small group of patients. So the idea is that maybe this is going to show even more benefit when they design the study in that way. So I'm done. Clinical trials of today are the treatments of tomorrow. There's many trials ongoing, especially for triple negative and for brain metastasis patients. There is hope, and thank you for having me tonight. Sorry for going over.
That was fantastic, Dr. Hilton. And I have to figure out how to take you off the spotlight. There we go. And I've vacillated back and forth whether to do all the presentations first, but I kind of feel like we can take like 3 questions now just to keep on time. So I don't know if anybody has any particular questions about that particular presentation.
You know what, though? Dr. Puhalla is going to be talking about the immunotherapy with triple negative, and I think she has some really cool data. So the people that are interested in triple negative might want to hold off until after she talks.
Okay, that's an excellent suggestion. Okay, so up next is Dr. Puhalla, which I can't find your square. Searching for you there.
To me, it looks like that I'm to the direct left of you, but that might not be the case on your screen.
Well, I have one square where you do not have you have your photo up, but not your camera on. Is that, do you have?
Okay, that's me, yep.
Okay, well, I will, if you want to start.
Yeah, can you see my slides here?
Yes.
Okay, perfect. So I'm gonna give myself a timer too, because I don't want to go over and be respectful of everyone's time. So as Dr. Hilton nicely introduced, I will be talking about immunotherapy, and immunotherapy is certainly a really hot topic in many cancers, and breast cancer is no exception, particularly triple negative. So what is immunotherapy? And at its very basic, immunotherapy is a type of cancer treatment that helps your immune system fight your cancer. So there's a lot of different parts of the immune system. You have B cells and T cells and dendritic cells and other cells. And there's really a complex interplay between cancer and between the immune system. And one of the main problems is that cancer is technically self. So the cancer started from your body, and the immune system needs to recognize that that cancer is different and that cancer should not be there. So in part, you need to activate certain cytotoxic lymphocytes, but you also need to deactivate immune regulation. So in general, our T cells are kept off, and we want to reverse this process in a regulated way. If you think about autoimmune diseases like Crohn's or Hashimoto's or rheumatoid arthritis, that's when your immune system is turned on and activated inappropriately. So these checks and balances exist for a reason, but we want to be able to use that as we're treating cancer. And for people that want to read a little bit more about this, on cancer.gov, there's a really wonderful section on immunotherapy. So I would encourage you to take a look at that. So to think a little bit further about immunotherapy, oftentimes when we think about immunotherapy and cancer treatment today, we think about checkpoint inhibitors. And checkpoint inhibitors are drugs that allow the immune system to recognize the cancer cell. And the two most common checkpoint inhibitors that I'm guessing many people are aware of, one is a medicine called Tecentriq. The other name for that is atezolizumab. That's approved in stage 4 triple negative breast cancer. Keytruda is another very commonly used checkpoint inhibitor. The other name of this drug is pembrolizumab, also approved in stage 4 triple negative. And basically, the PD-1 is expressed primarily on activated T cells, and binding of PD-1 to its ligands, PD-L1 and PD-L2, impairs T cell function. So PD-L1 is expressed on tumor cells and macrophages, and the tumors can use this to their advantage to an extent to evade the immune surveillance. And a really important point when we think about the use of checkpoint inhibitors, specifically in breast cancer and in triple negative breast cancer, is that these agents all appear to work best when they are combined with chemotherapy. And that's for a number of reasons. Chemotherapy disrupts tumor architecture, so these immune cells are able to kind of get into the tumor better. There's increased antigen shedding. And then also when we think about the action of immunotherapy, it's a little bit more of a passive action. So basically it allows you to rapidly control disease with chemotherapy, and then the immunotherapy can kind of come in as a second wave of treatment. So why is triple negative breast cancer a good target for immunotherapy? And as Dr. Hilton had mentioned, there's a lot of really nice sessions on immunotherapy at San Antonio this year. And there's actually a whole spotlight education series with some excellent speakers. This is Javier Cortez, who's a breast cancer physician from Spain who has been very actively involved in immunotherapy. So some of these slides are taken from his talk. But basically, triple negative has a higher mutation rate than other breast cancers, such as ER-positive breast cancers. Triple negative breast cancer also has a lot of T cell infiltration at baseline. And for those of you who have triple negative breast cancer, you may have noted on your path report a comment as to T cell infiltration. So already the immune system is involved in triple negative breast cancer. And then many triple negative breast cancers have expression of PD-L1. So triple negative breast cancer is really an excellent target inherently to combine immunotherapy treatments for it. We also know, as previously mentioned, that triple negative breast cancer is a very heterogeneous disease. And we used to kind of think, 30 years ago, we thought all breast cancer was the same. And then we became smarter and realized that there's estrogen positive breast cancers and HER2 positive breast cancers and triple negative. But when you take a deeper dive into triple negative disease, there's actually multiple different subtypes within triple negative. And it makes sense because we see such a wide variety of clinical outcomes with triple negative disease. But there's a specific type of triple negative called basal immune activated, and this is where perhaps immunotherapy works best. So perhaps if you have a mesenchymal or a luminal androgen receptor triple negative breast cancer, there may be different effects. But again, this is something that is in its infancy, but we are learning more about all the time. So thinking more again specifically in triple negative breast cancer, we have these two drugs that are approved, pembrolizumab and atezolizumab. And it's important to note that these are not necessarily interchangeable. So while they've been studied with the same chemotherapy backbone and while they've been studied both in triple negative disease, they actually do slightly different things in the body. So pembrolizumab is a PD-1 antibody and it binds to the PD-1 receptor on T cells, whereas atezolizumab is a PD-L1 antibody and it binds to PD-L1 on tumor cells and tumor infiltrating lymphocytes. There's actually two different assays that are used. So for those of you that may have had your tumors tested for PD-L1 or PD-1, it is important to note which assay was used. And there's certainly a great deal of overlap that is kind of outside the scope of this talk. But it's important to note, suffice to say, that there are different ways to measure. There's different companion diagnostics. And pembrolizumab was recently approved in first-line metastatic disease if the CPS, which is the way that the PD-1 is measured here, and it's in combination with taxanes or gemcitabine and carboplatin, whereas atezolizumab also has approval in first-line metastatic disease, but only with Abraxane. And in both of these agents, there is emerging neoadjuvant data that looks very favorable, and we'll go over that just very quickly this evening. So there are a number of studies in the neoadjuvant setting. The big studies are Keynote 522 and Impassion 031. In the metastatic setting, also Keynote and Impassion as well. And we'll take a little bit of a deeper dive into these settings. So in the neoadjuvant setting, so this is when you're getting chemotherapy prior to your surgery in early stage newly diagnosed disease, there have been a number of studies that have been evaluated. And what's really important when you're looking at the efficacy of these studies is to look at the chemotherapy backbone that the immunotherapy was given with. So for example, in Impassion 031, the immunotherapy drug was atezolizumab, and the chemotherapy backbone was adriamycin and Cytoxan and nab-paclitaxel or Abraxane. And the complete response rate, so that's our goal when we're treating triple negative breast cancer in the neoadjuvant setting, is how many folks have their tumor go completely away. That was 50% with the addition of the immunotherapy compared to 41% with chemotherapy alone. So a delta there of 17%. And something I'll point out to you with all of these studies is that if you look at the pathologic complete response rate, it is higher if you are PD-L1 positive compared to PD-L1 negative. But very interestingly, even if you are PD-L1 negative, the addition of the immunotherapy still improved the pathologic complete response rate. And this is important because it's something different than what we see in the metastatic setting. So a couple important notes. If you are PD-L1 positive and you received immunotherapy, your pathologic complete response rate was quite high, particularly with AC and taxane-based therapies, upwards of 69%, which is pretty fantastic. And that was higher than if you just got chemotherapy alone. But even if you were PD-L1 negative, your pathologic complete response rate was higher with immunotherapy and chemotherapy compared to chemotherapy alone. So these two studies here, the Impassion 031 and Keynote 522 are two large studies. You can see the Keynote study had over 1,000 patients looking at what happens when you add immunotherapy to standard chemotherapy. In this regimen right here, the Keynote regimen with pembrolizumab, Taxol, carboplatin, adriamycin, Cytoxan, this will be looked at by the FDA in early February. So it may be that coming up very soon, this is our new standard of care. That remains to be seen. Because importantly, we don't just want to shrink tumors and we don't just want tumors to go away. We want people to live longer with their disease. And that's really the main crux of this is, do patients actually live longer without their cancer coming back with the immunotherapy? And one thing that I think does bear mention is there was a study that looked at nab-paclitaxel or Abraxane and carboplatin without the AC chemotherapy, and there did not appear to be as great of a benefit or really minimal benefit with the addition of the immunotherapy drug. So it really, the chemotherapy backbone is important, and it's probably our full court press as far as anthracyclines, taxanes, platinums, in addition to the immunotherapy, where you get the biggest bang for your buck. So looking a little bit further into Keynote 522, because this is the regimen that's going to be looked at by the FDA in early February, the overall patient population, the response rate, the pathologic complete response rate was improved with the immunotherapy. And again, those patients who were PD-L1 positive did better. Now, what about side effects? So in this particular study, grade 3 immune effects were 13%. So overall pretty low. The most common immune effect was related to dermatologic, like rash, or involving hypothyroidism. So things that could be relatively easily treated, but occasionally people will have pretty significant toxicity with immunotherapy. So that's really your balance, is does that increase in efficacy, is that outweighed by an increase in toxicity or not? And we actually have some data from San Antonio that we'll look at as far as something called patient-reported outcomes, or how did the patients who were on the study feel about their side effects. So as we move forward into the metastatic setting, so similarly, very similar studies were done in metastatic triple-negative patients. One of these studies was in PASSION 130 with atezolizumab and nab-paclitaxel or Abraxane, and PASSION 131, which is atezolizumab and paclitaxel or regular Taxol, so to speak. And then the Keynote 355, which was reported initially in 2020, updated at San Antonio, where pembrolizumab was added to a variety of chemotherapies. I think what's important to note is this top regimen, the Abraxane with the atezolizumab. This has been FDA approved now for some time, does show an advantage in terms of progression-free and overall survival in those tumors that are PD-L1 positive. But very interestingly, paclitaxel or Taxol combined with atezolizumab did not show benefit. So particularly with atezolizumab, it appears to be important, the chemotherapy backbone. And what was interesting about the pembrolizumab studies is that the chemotherapy didn't appear to be as important. So let's look at that a little bit more. And I'll skip over this side. This is pretty much what I just said, basically that with atezolizumab, there was improvement in outcome. With pembrolizumab, improvement in outcome, but atezolizumab with Taxol did not have improved outcome. So again, not all chemotherapies are the same with immunotherapy, especially in the metastatic setting. So in Keynote 355, this was a study that was updated at San Antonio this year by Hope Rugo. And patients in this study had to be over 18. They needed to be first-line metastatic, so someone who had been treated in the adjuvant setting and then had their cancer come back. And if it came back with previous treatment, there had to be at least 6 months that elapsed. So if someone finished their AC Taxol, had their surgery, their radiation, and a year later the cancer came back, they could go on this study. Or somebody was newly diagnosed with stage 4 disease. And in this study, patients could receive a taxane, so they could receive either nab-paclitaxel or Taxol, paclitaxel, Or a third regimen was gemcitabine and carboplatin. And why this is important is that if somebody received AC Taxol in the adjuvant setting and then recurred, you would certainly want to give them a different type of chemotherapy. And in this particular study, they looked at PD-L1 tumor expression with CPS greater than 1 and CPS less than 1, and looked at whether or not they had had prior chemotherapy. In terms of the patient characteristics, I think the really important thing to note is that half of the patients received gemcitabine carboplatin, and the other half received one of the taxanes, which with the most common being the nab-paclitaxel. About 40% of patients on this study had a CPS score that was greater than or equal to 10. 75% had a CPS that was greater than or equal to 1. And about a third of the patients were newly diagnosed with metastatic disease at presentation, whereas the other group of patients are patients that were treated in either the adjuvant or neoadjuvant setting and then had their cancer come back and spread somewhere else, with most of those occurring, 50% of those, after 12 months. So when you look at the CPS greater than 10, I apologize because Hope Rugo kind of cut off this piece here. But importantly, what you can see is that in patients who had a CPS that was greater than 10, looking at the efficacy of chemotherapy with the pembrolizumab, the median progression-free survival, or how long the cancer was controlled, was 9.7 months compared to 5.6 months. And this was statistically significant. And I realize that's my 15-minute warning here, so I'll just quickly go through this. And importantly, if the CPS was greater than 1, so these were people who were PD-L1 positive, but not as strongly PD-L1 positive, there was benefit, but did not benefit to the same degree, and it was actually not statistically significant. Typically, we think of statistical significance as a p-value less than 0.05, but in this particular subset analysis, it had to be less than 0.0011, so that was not met. So that's why in the metastatic setting, there needs to be a CPS greater than 10 for approval. So just to move through here a little bit, one thing that I do want to point out to you is that there was not a specific advantage to one of the chemotherapy partners. So even though it may look like the paclitaxel had a higher objective response rate, that was not something that was powered for. And suffice to say that all of those patients who had a CPS greater than 10, regardless of what chemotherapy they had greater benefit with the addition of the immunotherapy. And then keep in mind as well, on the gem carbo arm, those were a lot of patients who had previously had chemotherapy. Less response in the CPS greater than 1. And when you look at everyone together, again, that response is diluted. So in terms of the duration of response, the one thing I really want to point out to you is that in the PD-L1 CPS greater than 10, the median duration of response with pembrolizumab and chemotherapy was 19 months, which is really very thrilling and exciting information, probably the best median PFS we have in this setting. So in summary, pembrolizumab plus chemotherapy is important. And I really apologize because I don't want to go over and not leave time for everyone to speak. But what I wanted to let you know is that in the neoadjuvant setting, there was a study looking at patient-reported outcomes. And basically, patient-reported outcomes are an analysis of asking the patient how they felt. And what I wanted to let you know is that the most important thing is that, I'll just skip here till the end, is that adding the immunotherapy to the neoadjuvant chemotherapy did not impose additional treatment burden on patients. So just to give you a brief example here, that if you look at role function, which is are you able to do the things that you want to do, certainly that drops down with chemotherapy, whether you're getting immunotherapy or not. But then over time, that improves back to baseline. So even though there are some autoimmune toxicities, there are not significant detriment to patient function or other potential chemotherapy toxicities. So that's what's really, I think, wonderful about the immunotherapies is that the non-immunologic toxicity is very similar to chemotherapy alone, as is patient function. So I'll go ahead and stop there. And, you know, if Jen, if we want to do questions now or later, I'm happy to entertain those.
Well, thank you very much, Dr. Puhalla. I think, and if I can, if you want to, you can take your slides down.
Okay.
At this point, if you don't mind, let's just continue through with the doctors, and then we'll do a large question and answer at the end, because it's I just want to I want
Sure.
everybody's times, but that was pretty incredible. A lot of great things coming out about immunotherapy and a lot to learn as well. And so Dr. Analo, I can't find you. Let's see.
There's no, I'm here. It's just, it looks like, even though I came back to work to try and get this working, for some reason it can't detect a camera. But so I'll speak without the camera. Let me share my screen. Give me a minute. Unknown caller. Give me 1 second, guys.
Okay, take your time. Oh, I should probably actually introduce you, shouldn't I? I didn't think I introduced you, Dr. Puhalla. Dr. Analo is a medical oncologist and hematologist affiliated with Allegheny Health Network Cancer Institute. She specializes in diagnosis and treatment of breast cancer. She's active in clinical research and is also a clinical researcher for numerous breast cancer trials. Dr. Analo received her medical degree from the University of Lagos in Nigeria, followed by a residence at UPMC Shadyside and a fellowship at Mount Sinai Hospital in New York. So we are grateful to have you here, and we're ready when you are.
Yeah, just bear with me.
Okay.
Technologically challenged here.
I feel your pain.
Yeah, just give me a minute. Let me try and share my screen here.
Okay. Well, does anybody have a quick immunology question or question for Dr. Hilton while we're here?
Where is my? Okay, here we go. Well, I'm trying to find where the share the screen is now. Oh.
It's typically at the bottom, a green share screen.
Yeah, hold on. I think because I had you. There we go. Okay, so let's see. Here should be my presentation. Okay, can you see my presentation, guys?
Yes.
Oh, success.
Yay.
So I'm one of the Allegheny Health Network medical oncologists with a special interest in breast. I'll be presenting just a few updates on the ER/PR positive cancers. Let me start my slideshow from the beginning. Give me 1 minute. Here we go. So in terms of the ER and PR and/or PR positive breast cancers, these form the majority of breast cancers. So for those of you listening, I'm sure about 75% of you, if you have breast cancer, will have an ER positive breast cancer. So certainly they form the majority. And we did have a few breakthroughs, more in terms of what we call de-escalation and more individualization of care in terms of the ER/PR positive cancers. So there are 3 studies with clinical impact that I thought would be great to share with survivors. And those 3 are the RX-Ponder clinical trial, which is a de-escalation trial. We'll go through it, using Oncotype DX in patients with early stage, but more advanced stage 2 cancers with 1 to 3 positive lymph nodes. And the goal was to try to avoid chemotherapy in a select group of patients. The second one we're going to go through is the RS clinical model, which is again using genomic tests with the clinical and pathological features of the patient to help define more clearly your own individual risk and your own individual benefit from chemotherapy. And this can be a real problem in the clinic, talking to the patient. And the third one that I purposely picked up and decided to bring out was the Breast Cancer Index. It's a clinical trial looking at various parameters, ER/PR status, androgen receptor, and comparing it to another genomic test called the Breast Cancer Index, which helps to determine whether or not there is a benefit to what we call extended hormonal therapy. So we'll start off with the first one. So the RxPonder study the RxPonder study results demonstrate that with the Oncotype DX test, chemotherapy use can be avoided in women with node-positive early-stage breast cancer. And as an introduction, I'm just going to go through, when I first started oncology in 2002, several years ago, any breast cancer patient arriving in the clinic with an ER-positive cancer larger than 1 centimeter typically got chemotherapy, at least 3 months of chemotherapy, followed by what we call endocrine or hormonal therapy, which would be the tamoxifen or aromatase inhibitors. If you had lymph node positive disease, we usually expanded on the chemotherapy and gave you 6 months of chemo instead of 3 months of chemo. And that was how everybody uniformly was treated. Now, with the advances we have, things have changed over those 18 years. And we have now genomic tests. And patients sometimes have problems with when you say, oh, I'm going to send your cancer tissue off for genomic analysis. Many times they think it's their own genetic testing. Oh, no, doctor, I did my genetic testing. I'm negative for BRCA. No, this is different. This is actually looking at the breast cancer tissue itself, the genomic study, looking at the genes within the cancer tissue that help to determine whether or not this is a low-risk cancer or a high-risk cancer. So unlike before where we had a uniform approach for everybody, everybody got the same, depending upon how advanced, depending upon your clinical and pathological features. With this gene test, which looks at 21 genes, we have been using that for over 10 years now, and it is approved for hormone receptor positive cancers, HER2 negative, initially just for lymph node negative breast cancers. And they look at 16 genes, what they call five which are more reference genes. They use a complex analysis to come up with a score, what we call a recurrence score, and it's anything from 0 to 100. If your result is above 25, then you're high risk, and everybody in the high risk group gets chemotherapy. Those who are below 25, we have those patients with low scores and what we call intermediate scores. We do not typically give all of them chemotherapy. So the TAILOR-X was a study that was done a few years ago, looking at lymph node negative breast cancers and looking at patients who were kind of in the middle. So patients with scores less than 11 were low risk, they didn't get chemo, but those kind of in the intermediate range, they allocated them to chemotherapy or chemotherapy, endocrine therapy, or chemotherapy alone. And these were the results. Those who were less than 50 with recurrence scores from 16 to 25, what was our intermediate group, may derive chemotherapy benefit. So you should still offer them chemotherapy. But for patients who are above 50, anything below 25, there was no chemotherapy benefit at all. So we went from giving everybody with a tumor size greater than 1 centimeter, lymph node negative, chemo followed by hormonal therapy, to using genomic tests like the Oncotype. The MammaPrint is another one that looks at 70 genes. And what we found is that with postmenopausal women, If your score was below 25, you did not need chemotherapy. And with these genomic tests, we are giving at least 30% less chemotherapy now with similar outcomes. So the question with this RX Ponder was, what about patients with lymph node positive breast cancer? Can we use the same data to determine who needs chemo and who doesn't? And remember, this is now stretching it a little bit. You're going from what are usually stage 1 to confined cancers, confined to the breast, now to cancers that have spread to the lymph nodes. 1 to 3 lymph nodes would be what we call N1, at least a stage 2, 2A, 2B, even possibly an early stage 3. So that's how this study came in, the RX Ponder clinical trial. There were 5,015 women with 1 to 3 positive nodes, with the Oncotype test with results in the lower range, who were randomized 1-to-1 chemotherapy followed by endocrine therapy versus endocrine therapy alone. They were split, about 1,600 were premenopausal and over 3,000 were postmenopausal women. And for those women who were for those women who had scores above 25, all those patients went to chemotherapy. Those are high-risk patients, post or premenopausal, and were not part of this analysis. So what did the results show? The results showed that postmenopausal women, women who had gone through menopause, with recurrent scores up to 25, had no benefit at all from chemotherapy. And this is a big, big breakthrough. The 5-year, look at it, invasive disease-free survival was 91.9% for patients who were just put on the pill. And for those who had chemotherapy followed by endocrine therapy was the same. There was no difference. So remarkable, certainly game-changing. We all know what chemotherapy can do to people. And if without all the side effects and toxicity of chemotherapy, you can have the same outcome, what could be better? So this is certainly game-changing. Now, there was one problem though, the premenopausal subset. Now, we always, oncologists have always known that the premenopausal breast cancer lady is very different from your 70 or 60-year-old with nice hormone receptor positive breast cancer. They may still, these are still hormone receptor positive, but they're premenopausal. We know that they have a worse prognosis. For some reason, the biology is just not the same. Now, premenopausal women, however, within those low scores, did have a statistically significant chemotherapy benefit. And it was because of this finding that although they had only gotten through 49% or about half of the events in this clinical trial, that they opened up, that they released the results, because this is important, that women who were premenopausal, they still needed chemotherapy. The average improvement in distant recurrence rate at 5 years was 5.2%. And the 5-year invasive disease-free survival was different for the two groups. It was 94.2%, as you can see in the chemotherapy and endocrine therapy arm, and only 89% in those who had endocrine therapy alone. There was also an overall survival benefit, which 1.3% may not look the greatest, but when you're fighting for your life, that sure is something. So this, at the end of this clinical trial, we can compare that to a trial called the Mindact trial, which was done using another genomic test for hormone receptor positive cancers, where they took high risk, low risk, what they call genomic high and genomic low risk patients. About 30% of those patients had lymph node positive disease. And in that Mindact trial also, they found similar findings, that a lot of patients with clinical high risk, which is large tumors or up to 3 positive nodes, who also had a low genomic risk did not benefit from the addition of chemotherapy. They also lately brought out that when they now did a subset analysis for patients below 50, even in the Mindact trial, even though this was not a subset they had planned to look at, they found that they possibly too had some benefit, additional benefit from chemotherapy. So these are practice-changing results. This will spare postmenopausal women, node positive. It will spare them from the short-term, long-term side effects and toxicities of chemotherapy without affecting outcome. So this certainly is a great study. It was prospective. It was randomized. This is something that we all have taken back to the clinic. We were all doing a little bit of that with the Mindact clinical trial and utilizing it. I think the one thing that many of us did not know or understand was that premenopausal women, even with what look like low scores or low risk on mama print, that we will have to be very careful with them and still discuss the pros and cons of chemotherapy. So that's the one clinical trial that I wanted to discuss. And then the next one, which is more, again, looking now at what we call individualized, oncology care, which is what we're all hoping for. This RS-CLIN model was another one which I found extremely interesting and something that I've already taken into my clinical practice. It's a new model. It was presented in San Antonio, which is incorporating what I described before, the oncotype test, the genomic test, and the clinical pathological features of the patient to define more clearly patients' individual risk as well as individual benefit from chemotherapy. That it's not just telling you on the whole, patients with this get this. This is now bringing it down to your particular level. Now, one caveat, it has only been studied so far in lymph node negative patients. It's also only available to the physicians. It is not part of your Oncotype DX report. It is extremely useful. It incorporates 4 clinical pathological features: the age of the patient. You see the importance of age again. Young people, premenopausal, poorer prognosis, the size of the tumor, very important, the grade of the tumor, and the recurrence score. I haven't brought a lot of graphs and a lot of, because, whenever I think of patients, I try to think of myself in the bank. When they're talking to me about interest rates and bonds, I get all lost. So I try to make it simple. I'll tell you that for the age, obviously the younger patients had a worse prognosis. In terms of the size of the tumor, patients with larger tumors have higher risk. The grade of the tumor, the grade, you look from the low grade to the high grade, the higher grades had higher risk. And in terms of the recurrence score, the higher the recurrence score, the higher your risk. When they incorporated all those together, they found that when they looked at the RS-CLIN as a whole, when they looked at the different clinical pathological features and the recurrence score, they found that patients where they combined these 2 parameters, both the clinical pathological and the recurrence score, was a better predictor of how the patient did. Now, how were they able to find that out? Well, they used a group of patients in Israel. They took patients where they already knew the outcome, and they looked at the model and compared it to the outcome of those patients and found that this score, this RS-CLIN score, more perfectly modeled the outcome of those patients. So this score is of particular benefit if you have scores that come in the intermediate range, where they can then put all these clinical pathological features to give you a clearer idea of whether or not the chemotherapy benefit is worthwhile to you. Now, the next one, the next The next abstract that I'm going to talk about incorporates another genomic, and I'm sorry for bringing all these different tests that seem, but it's something that may have an impact on what you will do in the future, okay? So the breast cancer index test is another genomic breast cancer test, and what it looks at is 7 genes. And these genes help predict the risk of a hormone receptor positive breast cancer coming back 5 to 10 years after diagnosis. Now, why is that important? Well, we all know that when you go to clinic, your doctor says, well, it's no longer 5 years, it's 10 years now, because there are many studies that show a disease-free survival benefit of about 3 to 5% with what we call extended therapy, which is 10 years of hormonal therapy, whether it's 5 years, whether it's 10 years of tamoxifen, or a sequential regimen, 5 years of one and 5 years of another, or 10 years of an aromatase inhibitor. This can be very hard on patients. Patients sit in my office almost like this is a prison sentence. When will this end? So the breast cancer index gives prognostic information as to the likelihood of late recurrence. Now, this is vital that you understand that patients with hormone receptor positive breast cancer, unlike the triple negatives, unlike the HER2 positive cancers, those ones, if they recur early, 2 years, maybe 5 years, you make it out 5 years, you can be singing Alleluia 90% of the time. The hormone receptor positive cancers, though, we know, keep recurring for up to 20 years after diagnosis, after treatment. And these late recurrences can be a problem. And that's why, you know, we have the 10 years, we have 10 years of hormonal therapy. There's no known overall survival advantage with it, but there is definitely what we call a disease-free survival advantage. Now, if we could predict who would benefit or not, it would save someone from 5 years, many times, of difficult times tolerating, for instance, an AI with bone pain and all that. So this breast cancer index does give this information. It gives you not only your likelihood of late recurrence from 5 to 10, but also helps predict the likelihood of benefit from extended therapy. So it is a molecular tool, like we talked about. It is approved for anything from what we call T1 to T3 tumors, even up to patients with lymph node positive disease. N1, however, it ends, which is up to 3 positive lymph nodes. Above that, very high risk of recurrence, would not be using this for that. It provides information, it gives you this individualized risk. This particular clinical trial now looked at other things. Are there any other substitutes we could use for the breast cancer index? Can we use the estrogen receptor, how much estrogen receptor expression, the progesterone receptor expression, the androgen receptor expression, what we call the Ki67? Can we use those things to predict for benefit in patients who are going to be on extended endocrine therapy? And they used a study called the TransAtom study. They used the blocks to look at that and to see if they could predict with that. The TransAtom study was a study looking at 5 versus 10 years of tamoxifen. I'm not going to bore you with all the different graphs. The bottom line is that the breast cancer index biomarker demonstrated a significant interaction with extended endocrine therapy. So it was able to tell, but the ER, PR, and the other parameters which you see that we look at in cancers should no capability for predicting the benefits of extended therapy. So you couldn't say, oh, your estrogen receptor expression is low, therefore you may or may not benefit. You should be the one that should be on extended therapy. So results confirm the body of evidence that breast cancer index is currently the only known biomarker that is predictive of a response to extended endocrine therapy. So just to let you know, it is now part of the NCCN guidelines. So the breast cancer index, I have no stock in the company, but certainly I have used it in my clinic over the years. You can use it in patients who have been 5 years on tamoxifen to determine whether you want to do 5 years more of tamoxifen. You can use it also, they've also studied it in the IDEAL study. They've studied it in patients who received what we call aromatase inhibitors, 5 versus 10. It's certainly worth doing if you're struggling through therapy and you've made it to 5 years and you don't know if you can get through another 5. This could certainly be something that you could discuss with your doctor and decide whether it is a test for you. Thank you very much. If you have any questions, I'll be here at the end.
Thank you very much, Dr. Analo. That's a lot of changes, a lot of good information on tests. We have a lot of questions in the chat, but I would like to move on to Dr. Brufsky, and then we can get we can talk about all the questions collectively. Dr. Brufsky is a professor of medicine at the University of Pittsburgh School of Medicine and also serves as an associate division chief of the Division of Hematology Oncology at the University of Pittsburgh School of Medicine's department. He's also the medical director at McGee Women's Cancer Program and part of the UPMC Hillman Cancer Center and UPMC Center. He's also the director for clinical investigations of UPMC at Hillman Cancer Center. And so when I find you, Dr. Brufsky, we can.
I'm here.
Oh, there you are. I'm gonna spotlight you.
Okay. All right, let me put my screen up. First thing is, I gave up, people keep putting things on. About 2 or 3 years ago, I gave up the clinical investigator piece because I want to do more breast cancer stuff. And, so they keep saying that, but it's okay. It was just an administrative thing. I'm glad I'm doing more of this stuff. Let me get to
I apologize.
So I get to do what I love to do, and I'm going to try and do it quickly because we want to do the questions, which are much more important. But let me kind of pull this up here. Here we go. Let's see. What's going on? There's a lot of really cool stuff going on in breast cancer. You heard just a little bit of it. I'm not going to go, I'll go quickly through this. Again, these are the kind of slides that I give to, as we all have, these are the kind of slides that I give to doctors. And, I'll kind of go through a little bit of this. And there's so many cool things, both in the stuff they've talked about already, the other doctors on this call, and me. It's hard to fit it all into this 2-hour time frame just because of the excitement. And there's even more stuff not even going to, we'll maybe bring up some stuff. I think that breast cancer is really going in a really interesting direction for the next 5 to 10 years. And we're just scratching the surface of it, the immune therapy in particular. But I just want to talk a little bit, and I'll give you a case of somebody, a 62-year-old woman had a 4.5 centimeter breast mass and had some lymph nodes under her arm. And we biopsied it, and it's estrogen receptor and progesterone receptor positive, and it's HER2/3+. And we generally give this woman, and someone on this call maybe like this, we gave you TCHP, which is a chemotherapy regimen, and then had a mastectomy, and there was still cancer left. And the question is, if you have cancer that's left after this, what do you do? That's really the question. And I think a question that we've been asking for a long time, and there's a trial called Catherine, where normally we would give people Herceptin and now Perjeta, but what we do is we give them instead Kadcyla, TDM1, in this trial. And some of you on this call may have been on this study. We put a lot of people on this trial, and actually, I think I was on the paper, Dr. Stogie was on the paper in the New England Journal of Medicine on this, that Chuck Geyer, as you can see it below, did. And, and so this trial was really interesting. And what we found just really quickly in this trial is that basically, you can see here, the most important thing is that you had about a 20% chance or so of recurrence in 3 years if you just had trastuzumab alone. But if you got the Kadcyla, it went up to 88%, almost 90%. And so that got everybody really excited. And, this is actually mostly when we see these trials, what we worry about is whether the cancer is coming back just in your breast, which you can treat surgically, or elsewhere in your body. We call it distant disease-free survival. And even that was improved, as you can see here, by about 6 or 7%, from 83 to like 90%. And even the overall survival began to be improved as well, because most women with HER2-positive breast cancer are going to recur if they do within the first 3 to 5 years, and really more like 3 years, to be honest with you. And so if you block recurrence in those first 3 years, it's likely that someone is going to live with their breast cancer and never die from it. Well, theoretically, we hope. And so that's kind of what it was doing. The issue with TDM1, just to kind of show you quickly, and again, this is just a background of what I want to talk about. The issue of TDM1 is that it can cause some fatigue. It can cause kind of some neuropathy, numbness of the fingers and toes. And a lot of women in this trial, actually, probably about 25% of the women actually came off the TDM1, the Kidsilla, because of side effects. And even though they came off it, they still benefited from it. So this is why we still started on everybody, but understanding that a number of women may come off it and just get Herceptin and Perjeta again. So, the issue is that what about these other agents? That's really cool. That's great. But what about things like HER2 tyrosine kinase inhibitors? And so the idea is that Herceptin binds to this area, right? What's called the outer piece, what we call, well, there's a fancy name is extracellular domain. And so Herceptin, which is trastuzumab, and pertuzumab, which is Perjeta, bind here and block it. But these other molecules like neratinib, which is Nerlynx, and lapatinib, get into the cell, and now actually tucatinib, which we're not going to really talk about too much, get into the cell, and they bind to this internal part. And this is important because it turns out in some HER2 positive breast cancer, this piece is chopped off. It's not even there anymore. We call it P190, we call it P95. And actually Bayer has a test where they detect it in the serum. And we've been trying forever to see if it correlates with survival in breast cancer, HER2 positive breast cancer. And, we don't know. I mean, Bayer would love you to order the test, but the problem is that we're just not sure if it works yet. But still, what this says, if you have one of these HER2 tyrosine kinase inhibitors, A, they can work where maybe this piece is chopped off, okay, which we don't know how often that happens. And B, they get into areas of your body. This is the most important part. They get into areas of your body that the big molecule, this big Herceptin or trastuzumab molecule doesn't get into. Now, you heard Dr. Hilton talk about sacituzumab govitecan, the Trodelvy, getting into your brain. And that's really fascinating how it does it. But generally, most of us think that these molecules don't get into the brain, at least for now, actively. It's a really complicated subject that's going to get more clear, I think, in the next couple of years as we kind of understand a little bit more about what's going on. But the thing is that these small pills, these molecules like neratinib, get into the brain, and that's really important. So, Extenet really was a trial that people had their typical therapy for HER2 positive breast cancer, and then they had a year of Herceptin, chemo, and then a year of Herceptin, and then afterwards got either neratinib for a year or placebo. And actually, what you can see here, this is after 5 years. There's a small but significant benefit. I mean, it's not huge, it's about 2.5%, but that's on the order of what chemotherapy gives some people. And so you are getting some benefit from an extra year in neratinib if you have HER2 positive breast cancer, but we really wanted to, not everybody should get it because it does cause a lot of diarrhea. And I think a lot of women, as I think you guys know, you're done with your therapy, you're finished, you want to get out of here. You don't want to be on it forever. You don't be on therapy for 2, 3, 4 years. And so, we want to say, okay, who do we really need to give this in? And it's interesting when we look. This is actually data that was presented at our ESMO meeting, which is a meeting that usually is held in Barcelona because the pandemic this year was online, like everything. But what they showed at our ESMO meeting is that if you had neoadjuvant chemotherapy, like the woman that I just showed you, okay, and had residual disease, and then got a year of Herceptin and then got neratinib as well, the people who got neratinib not only had a pretty substantial benefit, you can see here about 8.7%, which is basically, a reduction in the risk of recurrence by almost half, or they actually even had an overall survival benefit of about 10%. And it really started here pretty quickly at about 2 years. And so people are like, wow, this is kind of interesting, and I think people got really excited about it. And they got even more excited about it, and this is where I get into it a little bit, is that, and this is kind of where we're going to get to the stuff that was done at San Antonio, what they found when they went back to that Catherine study I showed you before of the TDM1 molecule, the Kidsilla molecule for a year, again, about 10% of the people recurred. Half of those people recurred in their brain, okay? And so that's really important. With HER2 positive early stage breast cancer, half of the recurrences, God forbid, if they come back, do seem to occur in your brain. And so what we're trying to do now is give you things up front with that TDM1 that prevent it from getting into your brain, okay? Or if it's in your brain, stop it from growing. That's the whole point. And a lot of us have gotten very excited about it. And in fact, this is the abstract that was shown here. So this is basically the ExteNet study showing the final overall survival. And really, there's not a lot of difference in overall survival, which is kind of surprising when you look at the overall population. But again, when you look at the hormone receptor positive group, there is a benefit, okay? It's not significant. It was 2.1%. But what we see is we look at this hazard ratio. If this number crosses 1, we ever look at a clinical trial and the docs are talking like me with all these fancy things, you just look at this hazard ratio. And if this number is above 1, then it's not statistically significant. And we're not sure whether it's real or because of just chance analysis. But what's most important is that if you had neoadjuvant chemotherapy here, and you can see this over here, let me just move this over so people can see it. If you had neoadjuvant chemotherapy, and if you see here, there's actually a benefit, of 9.1% overall survival benefit if you had residual disease after neoadjuvant chemotherapy. And most of the women who have that residual disease have hormone receptor positive, or triple positive, early stage HER2 positive breast cancer. So that's the people who benefit. And the question really now is why? And it turns out when you look carefully, these are very, very small numbers. And I've been dealing with Puma, full disclosure, I consult for them to try to help them figure out their trials. But the thing is that we were looking at this and we said, well, let's look at the amount of brain mets in the people. And what you can see here, the people on neratinib only had 4 brain mets, and these had 12 out of placebo. So it was half of the people, these recurrences. So, and these are the people with prior neoadjuvant therapy, 6 had brain mets versus 1. Now, these are very, very small numbers. Okay, but they tell us something that may be going on here, that these small molecules, these HER2 tyrosine kinase inhibitors, actually get into your brain, and they may prevent you from getting clinically apparent brain mets if you have early stage breast cancer. That's the theory behind it. We're doing a huge trial now where people, it's called COMPASS. It's about to start, and it's for people with HER2 positive breast cancer that have residual disease. They're going to get Kadcyla with or without tucatinib, which is the other HER2 tyrosine kinase. And the reason we're going to use tucatinib is that people get a lot of diarrhea with neratinib. It's the biggest problem. But it turns out if you do dose escalation, and if you give some of these agents, you can see here loperamide or cholestyramine or budesonide, you can kind of block it. But still, it's a little bit more cumbersome than tucatinib. And I'm just going to do tucatinib because I want to end. I could talk forever. As you can tell, I love talking about breast cancer. It's kind of what I do. But the thing is that, I'm going to stop after this one, and we can talk about some of these other big molecules later. But I know you guys have questions, and we've been going on. All the docs have been talking too long. So like me. And so, we just want you to have questions at the end. So I'm just going to talk about one last thing, and that's tucatinib. And it's really interesting that tucatinib is the same thing basically as neratinib. The way we know this is this cellular selectivity thing here. This tells us how much it inhibits the HER2. And you can see here, tucatinib and neratinib are 7 and 8. It's about the same. They're all better than lapatinib, which is really bad. We stopped using lapatinib because it's like, look at this. It's like much better. This is 49. So we stopped using lapatinib. And so we use either tucatinib and neratinib, but tucatinib doesn't bind what's called the epidermal growth factor receptor, and that's present in your colon. And so, but neratinib does. And so this is why you get a lot of diarrhea with one and not the other. And so this works really well. So it's kind of like neratinib without the diarrhea is the best way I describe it. And so there's this large trial. This is now the metastatic setting. It's called HER2 Climb, where we took women with HER2 positive metastatic breast cancer who've been through 2 different regimens. They'd already been through THP, which is a common chemo, and they've been through Kadcyla. And then they got either Herceptin and Xeloda with or without tucatinib. Xeloda is a pill. It's an oral pill that a lot of women take with Herceptin. And they got that either with or without tucatinib. And so the bottom line is the people who had almost all the people relapsed who had the placebo part with the trastuzumab capecitabine, but about a third didn't, who got the tucatinib. And it was everybody here, actually. Didn't matter. It was called a forest plot. We look at all the subgroups. If they all move to one direction, it means you've got some sort of effect. But the interesting thing is the people who had brain mets, you can see here fully a quarter of them didn't have progression, and everybody progressed who got the placebo part. That is, it didn't get placebo. They got something. They got trastuzumab capecitabine, but they didn't get tucatinib. And so that's really important because it turns out about half of these women who had brain mets didn't get any radiation. The doctors went to the patients and said, listen, we're just going to give you tucatinib. We're not going to give you radiation. A friend of mine, Erica Hamilton at Sarah Cannon down in Tennessee in Nashville, she had a woman with like a 4-centimeter brain metastasis, and the woman was asymptomatic. And she said, do you want to go on it? And the woman said, sure. And she did, and it shrunk very dramatically, actually. And we have a lot of cases like that now. So because what we want to do is avoid radiation when we can to people's brain because it has long-term side effects. We expect you, if you, God forbid, get metastatic HER2 positive breast cancer, we want you to live a long time. And that means that if you get radiation to your brain, you start to get some of the side effects of that radiation. So we want to prevent that from happening. And so that's kind of why we do this sort of thing. And just look at the overall survival. You can see here, it doubled the overall survival, especially people with brain metastases. So this is this last thing, just showing you kind of how it clinically helps people. Those are all just dry numbers. But the important thing at this year's San Antonio is that they actually showed whether people's quality of life deteriorated with brain mets or not. And what you can see here, looking at the bottom, don't look at this top panel, but look at the bottom. You can see if you get tucatinib, you see here, your quality of life with brain metastases was better. Okay, so really we think the biggest effect of Ducatinib in this trial has to probably be doing with the brain mets. And I'm going to stop there because I think you guys really want to ask questions. We have about 25 minutes left. I mean, let me see what else I have here just before we go. Actually, I do. All right, let me finish. I'll do this. I have like 5 more minutes to do this. Why not? So, the other big thing that people know about, I think you've heard about, is trastuzumab deruxtecan. And again, this gets back to this thing about this antibody drug conjugates. It's this really cool new way of doing it. We make an antibody to a particular protein on your cancer cell, then we link chemotherapy to it. And what that does, that's Kadcyla does that. We talked about Trodelvy, sacituzumab govitecan. This is Enhertu, which is trastuzumab deruxtecan. They all kind of work the same way. They deliver chemo directly to the tumor, and then because it's so targeted, kind of a magic bullet. I hate using that word, it's such a cliche, but the thing is that because it's a magic bullet, it goes directly to your tumor and delivers the chemo. So you can deliver a lot less, you have to do a lot less chemo. So you have fewer side effects from it. And so, the whole idea here, it's really interesting. There's all this complicated science that goes way beyond this. But, this linker is cleaved in certain areas of the cell and outside of the cell too by very specific enzymes. And where it's cleaved, it's going to turn out to be, it's going to be really, really important in the cancer, whether it's in something called the lysosome, if you remember your high school biology, or whether it's an extracellular space. It's going to be really, really important, it turns out. But that's the next 5 years of this business. We're going to figure this out because we know it works so well. And, this is this trial where it's a phase 2 trial where they just gave the trastuzumab deruxtecan to people. This is showing that last year, San Antonio. And what they found, and these are people who had a lot of different chemotherapies for their HER2 positive breast cancer. They progressed through like 6 therapies on average. And almost everybody responded to the Enhertu, almost everybody. This is like a 97%, this is a 60% absolute response rate. But you can see here, if this goes down, it means you either had stable disease or responded. Only 3 people out of 184 actually had progression. And they didn't even have progression over this magical 20% limit. They'd be considered stable disease. So everybody responded to this. And so, it's really important. And then looking at just at the progression-free, the overall survival wasn't reached in these people. And, it looks like 16 months, they didn't progress for almost 16 months, over a year and a half. And so this is really exciting. So all they did at San Antonio this year is they updated the data, and they showed that you now have a median progression-free survival of almost a little less than 2 years, 19.4 months. The overall survival, it kind of plateaued. There's still a lot of people who are still alive because they weren't progressing. So it's kind of like, they think it's 24 months, but there's a lot of people we call censoring. They're still alive when they did the survival analysis. So we're not quite sure if this is really real. I think this needs to what we call mature a little bit, as well as there's a big phase 3 trial where they're doing this. This is just a phase 2 trial. They're actually doing a big phase 3 trial where they're comparing it to Herceptin and Xeloda. And that trial is called Destiny Breast 03. Hopefully we'll see that data either at ASCO or San Antonio next fall, or the European meetings, or at San Antonio. So with that, I'll kind of stop. And, I just think that brain metastases are going to be really, really important in this disease. I think that they're important in all diseases. I mean, maybe a little less so than ER-positive breast cancer, but in triple-negative breast cancer and HER2-positive breast cancer, it's going to be a big deal. And I think that's going to be the next big movement in our business, is try to figure out what to do about it and how. And, for a guy like me who's been doing this a long time, and, and the excitement never ceases, because I think there's always new things, that we've all talked about over the last hour and a half, that can really help patients like you get better. And so with that, I'll kind of end. Okay.
I'm on mute. I'm sorry. Thank you, Dr. Brufsky. There's a tremendous amount of information that was delivered here tonight, and I do want to get to everybody's question. And so we do still have some questions in the chat already, and we can go over those. But if you want to continue to add the questions in the chat, and then we can try to open it up. If you would like a specific doctor to answer the question, if you could just note that in your question. Otherwise, we could just open it up to all the physicians to answer. But I know Carol said she has something that she had a specific question off the bat. And Carol will help me with the questions in the chat. But Carol, go ahead.
Dr. Brufsky, I was like super excited that you talked about neratinib, because I was diagnosed with inflammatory breast cancer 7 years ago, and I was on phase 2 trial, and I got to meet Alan Aubach of Puma Biotechnology, who started with the investigation of this drug. So I had it in the neoadjuvant phase, and with inflammatory breast cancer, now I'm cancer-free, and I feel like because it gave me added extra protection to the brain, which I did not know at the time. What do you think my chances would have been now of it metastasizing to the brain, that I was diagnosed stage 3C, if I wouldn't have had neratinib?
Again, it's about half of the recurrences are in your brain. And I think that probably what the neratinib did in your particular case with inflammatory breast cancer, because, it's interesting, just kind of parenthetically, they have the U.S. Department of Defense program for breast cancer, and so just to talk about inflammatory breast cancer, there is a place at MD Anderson, that's all they do. It's like 5 docs that do nothing. I don't know if you've actually consulted with them. That's all they do is inflammatory breast cancer. And we're reviewing their grant. They have this grant panel. We're reviewing their grants on Tuesday. So some really cool stuff of inflammatory breast cancer. I can't talk about yet because their grants are confidential, but there's some pretty cool stuff. But nonetheless, yes, I think this is what happened probably in you, is that it hopefully, you're here, and usually
Right.
breast cancer, HER2-positive breast cancer is going to recur within the first 3 years. So it's unlikely that you're going to get anything else, thank goodness. But it's likely, if I had to take a guess, it's likely that the neratinib you got in the clinical trial probably prevented you from having brain mets. I would say it's likely.
And my question is to you, just another one, is that, I did consult with MD Anderson, then decided to stay in Pittsburgh.
Yeah.
Why do they not talk about inflammatory breast cancer at many of these conferences? Is it because there is such a small majority of women that are
Yes.
diagnosed with inflammatory?
Yeah, that's exactly right. It's because there just aren't a lot of people with inflammatory breast cancer. It's less than 1%. It's like 1% or so, 1 to 2%. And so this is why the government has decided to now fund these rare cancer programs, where guys like me are going to review the grants, which is what I'm doing next week. And so because we need to get people involved in this, these are what are called orphan diseases. And for that reason, all the more reason, if you got an orphan disease, or you have a disease that's not common, and we come to you to say, listen, you have an orphan disease, or you have an uncommon presentation of breast cancer, please participate in our trial. And it's really, just a plea for trials here. But, you're not a guinea pig. You're still going to get the standard of care, just something better, hopefully.
Right.
And that's really, why. And so yes, this is why we don't talk about it, because inflammatory breast cancer is probably a little bit different, I think, although it's going to teach us a lot about the immune system in cancer, I think, at the end of the day. But it's just so rare that pharma doesn't want to deal with it. No one wants to put all the money into big trials of inflammatory breast cancer. Very good point.
Okay, thank you.
There are a couple questions that haven't been answered in the chat, and I'll start with one. If breast cancer seems to occur within the 3 to 5 year window, why doesn't insurance cover regular scans? Why wait until you feel a change versus catching something visibly before it's large enough to be palpable?
My colleagues got to take that one.
Who?
Shannon, Christine?
Shannon?
Yeah, I can take it.
Alex,
Sure.
you wanna take that?
So a couple kind of caveats to that, and I will say it's certainly from a patient perspective, this is a question that we get all the time: is why aren't we doing scans? Why aren't we looking for recurrence? Because with early stage breast cancer, there's such a push for mammograms and early detection, and then you have breast cancer, and then you're kind of told, well, we're just going to wait until the cancer comes back. And I will say, it sounds pretty oxymoronic, but the data behind that is there was a study, and I will kind of give a couple big caveats to the data. It's, for a long time, we treated all breast cancer the same. Everybody got chemotherapy, some people got hormone therapy, but certainly kind of thinking about breast cancer subtypes as determining treatment is a newer phenomenon. However, with that being said, there have been studies done that looked at doing scans and studies that looked at doing history and physical, which is you go to your doctor, they ask you what your symptoms are, they do an exam. And basically, the long and short of it is what those studies showed is that if you were getting scans versus just physical exam, on average, cancer recurrence was found 1 month sooner, and there was no difference in survival. And the main reason for that is a couple-fold, one of which is that breast cancer travels through your bloodstream. So it's very unlikely for it to be in one place only. So it's certainly, there are exceptions to the rule, but most of the time, if cancer is stage 4, it's going to be in more than one spot, and it's not going to be treated surgically like it is an early stage disease. The other really important kind of thing to understand about stage 4 disease is that it's not how much disease you have, it's how well it responds to therapy. So you can have 5 lung mets and not respond well to chemo, or you could have 20 lung mets and respond well to chemo, and the 20 lung met person is going to do better. So a lot of it has to do with the underlying biology of cancer. Now, one of kind of the important caveats of that is that we know that breast cancer recurrences are different. So we know that the ER positive folks, about half of those recurrences occur before year 5, but half of those recurrences occur after year 5. Whereas in the triple negative or in the ER negative HER2 positive patients, the bulk of those recurrences are in the first 5 years. So I suspect that over time, our look at recurrence is honestly going to be really determined by molecular testing, like circulating tumor DNA. So I think that kind of the idea of doing scans for surveillance, we don't do them because they've not been shown to be helpful for all of the reasons I just discussed. But I do think that with time, kind of surveying for recurrence may be more nuanced and may switch to more of a molecular level. I don't know if any of the other physicians want to add to that.
And would anybody else like to?
Oh, I'm sorry, Jen.
No, Dr. Puhalla just asked if anybody else wanted to add to that particular question.
Yeah, I mean, I think that it turns out that people have studied this, and I think I reviewed a paper a couple of years ago for some journal where in Canada, they looked at people who had a recurrence of breast cancer, distant, not local in your breast, but elsewhere in your body. And they asked them, well, how do they find it? Did they find it by scans, or did they find it by a woman saying she had symptoms? Okay. And it turns out that the vast majority of people, like 90% or so, they had a symptom that drove them to come to their doctor, and then they scanned them. Very rarely, only like 5% of the time, did they detect it by scanning somebody who was asymptomatic. And so, that's, we call that yield, docs call it the yield of the scan, what we call the pre-test probability. And because of that, that the scans are such low yield, most of the professional organizations like ASCO have really recommended that we don't do scans in that time. But on the other hand, it's for peace of mind. You're not just treating below, you're treating here too. And, so as doctors, we have a little discretion on this. And what I've done in my practice is knowing all of this, and someone really wants to get scanned, we have a talk about it. Right. And if someone really wants to do it, understanding that 90% of the time, 99% of the time, we're going to find, if we find something that's going to be benign, like a cyst in your thyroid or a cyst in your liver that's benign, that if people understand that going into that, I will do scans with them. But the insurers don't want to pay for it. They just think of the bottom line, which is how much money they're spending. And, they don't want to have people willy-nilly do scans on everybody. So it's kind of a difficult decision. What a lot of us tend to do, as Dr. Puhalla was just saying, is that what we do is that we say, okay, if you have a really higher risk of recurrence, like you've got a big cancer or stage 3 cancer, lots of lymph nodes, or inflammatory breast cancer, we will scan you up front. That's what I'd love to hear what my colleagues say about that, but I suspect that's what we do in practice.
Right. And as Dr. Brufsky said, I think it's certainly, it's not that we want to do an intervention because it's been shown to be helpful. And I think as we understand breast cancer more, it just doesn't, all of the studies show that those scans aren't helpful in the absence of symptoms. But again, it's as Dr. Brufsky said, we're treating the whole patient. And certainly what I tell folks is if you're really, really worried and there's some reason why you're worried, it's something that we can look at. But again, it's with the understanding that there's all of these caveats. And interestingly, one of the old Italian studies that we quote all the time actually looked at quality of life. So did people who get scans worry less, or did they have a better quality of life because they were getting scanned and therefore could say, okay, my eye scans are good, my cancer hasn't come back, I'm going to feel good about this. And the answer to that in that clinical trial was they didn't feel any better because they were worried about the scans. Sometimes you'd find something like a cyst or a nodule or all these little things that pop up on scans, and it made them worried. And sometimes people got interventions they didn't need because the scan showed something that ended up not being cancer. So somebody gets part of their lung cut out, for a benign nodule, that doesn't really help you either. So it's completely nuanced. And I certainly urge everyone who has questions about that to discuss their particular case with their physician.
All right, thank you. I think we have, I keeps moving. Are the HER2 new plus women still receiving Herceptin or biosimilars with, whoops, that keeps moving to canatinib, which I'm not saying, and neratinib. I don't know, Dr. Hilton, you want to chime in, or I don't know if I'm just trying to spread the wealth around there.
I'm sorry, can you repeat the question?
Okay.
You want me to read it, Jen?
Yeah. Go ahead, Carol.
Are the HER2 positive women still receiving Herceptin or biosimilars with tucatinib and neratinib?
I think I don't understand the question. So the HER2 CLIMB trial involved tucatinib along with capecitabine and Herceptin, and that's in the metastatic setting. Neratinib is approved in the metastatic setting, but it's also approved for women as extended adjuvant therapy, which we typically will talk to people about for a small benefit in ER positive, HER2 positive disease. Dr. Brufsky, did you understand the question a little bit differently?
Yeah, I do. And so the thing is that just about everybody now gets some. So what partner are we using with the tucatinib? And the answer is going to be biosimilars. Most, I don't know what AHN, I'm curious my AHN colleagues do, but at UPMC right now, we automatically substitute it. So, we use, I think it's Cangenti or something. Shannon,
Yeah, I didn't understand that that's what the question was.
Yeah, that was it.
I forget what it's called,
completely insurance dependent.
With it. Yeah, exactly.
Yeah, completely insurance dependent, but we're okay with it. Yeah.
Yeah. So everybody's switching to biosimilars because they really work the same. I mean, as far as we can know, they have to. That's what the law says. The biosimilar law says you have to demonstrate by as much as you can that's why they're biosimilar, because they have to be the same. If they're better, they have to do a whole other clinical trial. So they have to be the same by law.
And I think that patients should feel good about that because HER2 CLIMB included biosimilars. So patients on that study, that data is from patients who received biosimilars. So they should feel okay about that.
Yeah.
Okay. Carol, do you want to take the next question?
Sure. Is it still standard treatment to stay on Herceptin plus Perjeta for an infinite amount of time / unit, or if you have progression, is there also an alternative? Any of you like
just to let you know that I think I've been practicing longer than anybody on this call. And I have women who got the original Herceptin in the clinical trials who are still getting it because they want to. That's like I've been practicing almost 25 years. And so there have been people on Herceptin for almost 25 years without stopping it. But the bottom line is, yes, the short answer is the clinical trials suggest that you continue the Herceptin and Perjeta until progression. And so that's what most of us do. We're going to get to the point where I think, and my colleagues can comment on this. We all have patients just like this, where if the Herceptin-based regimens now work so well in people, these anti-HER2-based regimens work so well that we have people who are out now 5-6 years who haven't had progression of their cancer. And we debate, and they have no cancer left. And we debate whether to continue it or not. And that's it's a good problem to have. Okay. It's people are doing so well that we can think about stopping their therapy. And I think it's a big unknown. I'm really curious to hear what my colleagues do. I tend to continue unless someone really wants to stop. I don't know what my colleagues, Shannon, Christy.
Yeah, I do. I really do the same. We don't know that that's the right answer necessarily, but I agree. I have people who've been on Herceptin since the late 90s, and it's as Adam said, a wonderful problem to have. I do think that there are toxicities. Certainly there's financial toxicity of cancer treatment, which is a really big problem in patients with stage 4 disease. Even something as simple as copays coming in, or it can be a huge problem. So I think that while on one hand, we don't want to mess with success, on the other hand, there are certain circumstances where I think it could be helpful, and it makes sense to kind of think about that sometimes.
Hi, this is Helen Analo. This is a big problem because there are many patients who are doing well. And the problem we have in Pittsburgh is we really don't have any clinical trial addressing this.
Yeah.
There is a clinical trial in development, which I'm very interested in, and I'd be happy to send my patient to either network for it. But I'm hoping we can get it in Allegheny Health Network, where they're looking at patients who've been stable with for over 3 years, and then trying to randomize them. I hear this is a study that is in development now. So I did find out about it in San Antonio because I've been looking out for a study like this, because I have many patients who want to stop, but want to do it so that we can learn from it. And the only way we can learn from it is in a clinical trial setting.
Okay, we have another question. It was for the ER/PR and HER2 negative first stage 2A grade 2 with angiolymphatic invasion and local recurrence, grade A1 grade 3 in DCIS in 21 months. Is the risk of recurrence high to return again before 5 years distantly? I'm sorry, I really kind of butchered that question.
Yeah, I saw that on. It's hard to know. You can't. Just hearing this is just hard to know. You can't really make a decision like that just based on this. You got to look at the whole thing. And you know what a lot of us would have done initially is oncotype on the tumor, either oncotype or mammoprint. I tend to use mammoprint, and we all kind of have our favorite ones. They all kind of generally do the same thing. We would do that on your cancer. Now, the question is, would we do it on the second cancer, the local recurrence? I think the local recurrence probably was more, and not knowing nothing about this case, and my colleagues will probably say the same thing, but knowing nothing about this case up front, it probably because the surgery just had a positive or close margin. And so, thankfully it wasn't a distant recurrence, it was more of a local one. So I think it's probably part and parcel of the same exact cancer. And so you probably have the same risk of distant recurrence as you had for the first one. And that would probably be determined by the characteristics of that particular cancer. Again, either by oncotype or clinical way, we have ways of doing it online. There's something called NHS Predict Plus, where we can kind of get your risk of recurrence from clinical parameters. So I still think it's to say the risk of recurrence is not much different because of that particular local regional thing. But I know nothing about your case. I'm just talking, very generally. And I think that it's hard to know.
Okay. There's another question. I feel like my body is going to give out even before the lines of treatment available. MBC 9 years, meds to the liver, de novo, HER2 new plus, ER/PR positive, was positive originally and it changed. I'm slowing down. Are there any studies to help our well-being while going through chemo with side effects, long-term damage? Don't get me wrong. I'm thankful for my daily pain and that I'm still here, but man, I'm running out of steam.
Oh, who's there? I look at who's on the line with Dr. Hilton. Let's let her answer the question.
Dr. Hilton has an assistant.
That extra person wants to hear the answer.
You probably want your mom back. We promised to be over by 9, but we're going a little long here. Any suggestions for?
Yeah, I would say don't give up. I mean, it's hard. It's a long slog. There's still a lot of stuff out there. There's stuff that you haven't even thought about. And, our job as oncologists is really to kind of help you kind of get through this with as minimal kind of toxicity as you can and living the life that as best you can. Obviously, in the middle of the pandemic, it's hard to live your life as well as you can. But given all of that stuff, it's our job as oncologists to keep you going. And we can adjust your chemo, add certain things, maybe to make you feel less tired. We have ways to do that if they work. So there's a lot just in HER2 positive disease in particular. There's still an enormous amount of things that are out there. I mean, I could list probably 15 things off the top of my head, just thinking about it, that have activity in this disease that we've tried over the last 25 years. And for that reason, just don't, I could, I'm not in your shoes, but, at least what I can tell people is there's still stuff out there for you.
Hi, this is Helen Analo. I think, as oncologists, we tend to focus so much on the cancer, but we really need to focus on the whole person.
Yes.
And this is something that many times we lose sight of. And as a patient, you should demand that things should be balanced, you know. Many of our cancer, you know, I'm sure, you know, here at Allegheny Health Network, we have integrative medicine that you can, you know, where you could go for acupuncture, massage. We have psychologists, we have dietitians. Cancer doesn't just, you know, affect, you know, that particular area, your bones, your liver. It affects everything, your whole quality of life. And it's really that balance that is difficult to achieve. Also, you have to know what you want. Sometimes patients reach a point where enough is enough. They don't want quantity anymore. They just want quality, and they are willing to give up on our medications that cause a lot of side effects, but many times may prolong life. So you have to think about what you want, what's important to you. If quality of life is more important and you're at the point where you want more of palliative care, comfort care, let your doctor know that. They can integrate palliative care into your treatment and help you. So you should not be at this point where you feel helpless.
Thanks, Dr. Analo. You made some good points. Okay, we have, the next question is, this comes from young mothers who still want to have, you know, more children. And she said, is there anything positive that, you know, they are looking at or being presented as far as doing studies on women who want multiple pregnancies? Any of you physicians like to answer that?
There was a trial that looked at women outcomes after early stage breast cancer, pregnancies after, that showed that women did well. There was no increased maternal morbidity. So I think that that was fantastic to hear about at the meeting. And of course, I think the person who was asking the question is well aware of the positive trial because they had mentioned that. But I think that that's also important too. That's something where, you know, after you've been on endocrine therapy, you discuss with your physician, you can go on that trial, go off of the endocrine therapy with the blessing of your physician in your specific case, and they can follow you for 2 years to see if you can achieve pregnancy at that point and then go back on. So hopefully there'll be more to come, but definitely we all refer young women for fertility preservation, and hopefully more will come out that's positive.
Okay, thanks, Dr. Hilton.
I think we have a couple more questions. It looks like some of them are answered though. Well, let's just, does anybody have, it's easier if you want to say them, if you want to raise your hand. I know there's, well, here's Celine. Are there any trials for those who completed treatment?
Depends how long. I think that, you know, we're trying to do that. That's a real gap, I think, in a lot of our care. By complete treatment, you mean after all of your endocrine therapy? For example, there are trials right now in triple negative breast cancer where people are getting all sorts of immunotherapy that we're trying out to prevent recurrence. There are trials in ER positive breast cancer, although they're kind of completed, where we're giving drugs called CDK4/6 inhibitors in addition to hormone therapy to try to prevent recurrence. There are trials of diet. There are trials of exercise. We actually have a really neat trial, if anybody's interested, of these little wristbands that you wear. I think you have to have metastatic breast cancer for it. Well, we have these wristbands, are called an Apollo device. You can look it up on the internet. We literally just started this trial like 2 days ago, where we put it on your wrist and it kind of somehow affects your biorhythms, you know, and you kind of calm down, or your chemo side effects are less. And so, or even just your fatigue is less. We're looking at it for fatigue for people. So, you know, but I think that's for late stage, not early stage breast cancer. I'm pretty sure of that. We just literally just started this trial a day or two ago. And so, we have trials like that. When you say done, it's hard to know done with what and where, but there are people looking at various things like this, yes.
I think we may have gotten them all. Unless, is there something, Carol, do you see anything that hasn't been answered?
Is ER plus cancer usually an indication, or ER positive cancer usually an indication of estrogen accumulation or poor mobilization due to low adequate levels of progesterone and thyroid function? Is there any studies of that, if that's worth reading? Any of you physicians want to comment on that? ER.
I'll take it if my colleagues don't want to talk. See, I like to talk breast cancer. It's like my thing. I can't stop myself. So it turns out that people have looked at levels of estrogen. For example, there's a big controversy about birth control pills. There still is a controversy. If you're on them for a long time, does it cause breast cancer? It's really been going back and forth forever. There's a controversy still about hormone replacement. People who are postmenopausal, you go on hormone replacement. Do you have breast cancer, higher or lower? And, I think I'll tell you, there's some recent stuff that's just come out, literally like a few weeks ago, very basic science, very hard for the average person to kind of get. It's even most docs, it's pretty complicated. But it turns out that androgens like testosterone may actually be cancer suppressors in ER positive breast cancer. And what that means is that there's peripheral conversion of estrogen to androgen. That's why, or androgens to estrogen. That's why all the bodybuilders, they want to, if you ever have a bodybuilder, they want to steal your Arimidex because they use that to gain muscle. And so it turns out that these androgens may actually be more important than we think. And that may explain a lot of what's going on here with all these, high estrogen, low estrogen. It may have to do with the conversion of estrogen to androgen. And so just stay tuned on that. That's still literally hot off the press. People are, a lot of docs even now, kind of like us, are just learning about it. And I think that, it's literally at the beginning. There are going to be clinical trials of androgen agonists. So not testosterone, because we don't give people testosterone because then you grow a beard and stuff like that. But what we want to do is there are drugs now that are androgen agonists that actually make you build muscle and have well-being, et cetera, that don't cause any of the masculization. There's a drug called endosabarm that's going to be in clinical trials, at least in late-stage breast cancer first, and then probably be put into early-stage breast cancer later. And so that may be something going on. Who knows? We just don't know yet. But this whole thing has suddenly got a little bit more complicated. We always thought it was, you just had high estrogen for a long time, and it was that and nothing else. And but it's going to be a lot more complicated now, and we'll just see what happens in the next 5 years, 3 to 5 years.
Thanks, Dr.
I'm sorry. Did somebody want to say something?
No, I just said thank you to Dr. Brufsky. I think most of the questions have been answered.
Yeah, I think so too. And there's a lot of compliments in the chat. Everyone is very appreciative of your time. I think it was an excellent evening tonight. I appreciate all the physicians, all your time and your expertise. I appreciate everybody else, coming in and spending your Thursday night with us. There's a lot of good things happening, but it's still very challenging. And, but I appreciate your hard work. I mean, the one thing I find fascinating about, watching these presentations is that just the amount of work, sometimes you just get so discouraged, but there is so much work and so many clinical trials that are really racing to try to find solutions and answers. And the puzzle is just very complicated with so many different types and stages and levels. And, I can remember when I used to think that breast cancer was one thing, and obviously that's not the case. But I'm very grateful, and I appreciate everybody being here. And I did record this, so I can post it on my page. And if anybody's interested in it, let me know. And I am incredibly grateful to Dr. Hilton, Dr. Brufsky, Dr. Puhalla, Dr. Analo. I can't thank you enough. I think it's been fantastic, and I want to thank you all. I don't know if you do anything you'd like to add, Carol.
No, I think I just learned so much more. It was so great to have this recap because, San Antonio can be so overwhelming for the regular person and patient like us. And I think it's great that all you physicians could really just hone in on what you thought the information that we needed. So thank you so much.
Yeah, and I don't know if anybody want to add a parting word or two, or you're welcome to. Dr. Hilton, do you have anything you want to stop with? You just want to?
No, just that tons of new things coming out, and there's always hope. So,
thank you, Dr. Puhalla.
Sure, absolutely. Just to echo the sentiments, just if you're presented with a clinical trial, certainly it's really important. It's the only way we make progress in this disease. And for something to get to the point of a clinical trial, it has shown a lot of promise so far. So certainly it's really daunting when you're diagnosed with breast cancer, and then trying to think beyond that and to go into a clinical trial is difficult. But certainly it's something I encourage people to think about and to look out for, and to help us continue the progress we've made in this disease.
Fantastic. Dr. Brufsky?
Yeah, I mean, just wait. The best is yet to come. I think that, one of the things is that, because we can't go anywhere for the last year, a lot of us have been thinking about this very problem of breast cancer. And, we've taken a pause just to kind of think it through a little bit more. And I think that some of the stuff that's going to come out in the next couple of years, especially around breast cancer, the immune system, is going to be pretty interesting and pretty cool. And I think that there's a lot of stuff coming out. I mean, is it going to be applicable to patients immediately? A lot of it, no. But on the other hand, I think that we're starting to you start to see this picture emerging of where it's going to be in 5 to 10 years. It's pretty interesting. So stay tuned.
Well, I just wanted to make a comment too about what Dr. Puhalla said. I'm sitting here and I mean, I just am so excited for all the patients that are on neratinib, and so many patients come to me and said, if I hadn't been on phase 2 or had participated, that this drug might not be available. And there may be so many other women in this call that also were on a clinical trial. So I think us as patient advocates need to keep encouraging to ask their physicians about clinical trials. What's new out there in clinical trials?
I think that's really important. I mean, everything that we've talked about that's where it all starts. And Dr. Analo, would you like to share anything before we close?
I just, I think I agree with everyone that oncology has evolved dramatically in the 20 years that I've been in oncology. And there are lots of new things on the horizon for every group of breast cancer patient, and that certainly the survival is better than 20 years ago. And there's definite hope. I think the only take-home message I would like for all the survivors is to remember to talk to their doctors about the way they feel on a general level, so that the doctor can take care of them as a whole, not just as a cancer, not just the cancer. So talking to your doctor, explaining to the doctor what your goals are, very important in order to achieve the best care possible and the best outcome.
Well, that's a perfect way to wrap up. Well, thank you, everybody. I really appreciate everybody being here, and hopefully we can do this again, and have a great night and a great weekend.
Take care.
Bye.
Bye. Thank you very much.
Thank you. Bye.
Thank you.
You're welcome. Did Carol log off? I think she did.
Hey, Jen. Thank you.
Jen, I am so sorry, Jen. Did you have a question?
No, I just wanted to say thank you to all of you.
Oh, you're a doll. Thank you for always supporting me.
Well, you deserve it. You deserve people support you. You and Carol Glock and all those doctors. I mean, to take their time to do this was really very kind of all of them.
It really was. I mean, I'm sure they're exhausted, and poor Dr. Hilton's son is exhausted, wants to go to bed. Yeah.
Well, anyway, thank you for all this.
Well, I mean, there's a lot of questions and a lot of, you know, it just was, it was new. It was challenging, but it was new. It worked out.
I can't wait till we can meet and go to meetings in person. I've had,
You and me both. You and me both.
so we'll hope for that. You take care, okay?
All right, Jen, you too.
Okay.
I'm not, how about, you want me to,
I'm still here.
I know, but
There's other people that are still on too. I know.
yeah.
I think it went amazingly well, Jen. I do. I think that a lot of people. That's for sure. It's awesome.
Yeah, it was good. Maybe how about if we,
I'll call you.
okay. All right. Bye-bye.